Good morning, everyone. Um, it's great to see all of you here. Lots of familiar faces. Um, so I'm a general dentist. I'm not a specialist in any dental field, but somehow I got into this role. Um, but mainly I see head and neck cancer patients here as a general dentist. And this morning I'm going to talk to you about teeth-related issues, um, you know, during and after head and neck cancer treatment. Um, Before we get started, I have a, how do I do this? There we go. I have a disclosure statement that I have no actual potential conflict of interest in relation to this presentation. Okay, so um, before we get into the actual complications, I should go over, why is it important? Why is preventing dental complications important after um, head and neck cancer treatment? Some of these are kind of obvious. Um, you want to prevent painful problems from arising, right? Um, while receiving treatment for head and neck cancer, you don't want to have to deal with other pains, um, any additional pains. Taking care of one's teeth helps to improve the standard of life. It, because there's you have the ability to take in nutrients, and uh, it helps to maintain energy and strength, and um, it helps to your body's ability to kind of recover from the cancer treatments, uh, and tolerate the treatments that you're undergoing. Uh, and having sound dentition also improves the quality of life, right? And most of us enjoy eating, and it's much easier with your teeth. So the last reason on the list is not so obvious. And that's when there's like a rare or an unfortunate case of cancer recurrence. And in the, in cases like this, serious dental issues can actually delay cancer treatment. So you want to make sure your teeth are okay in case something else happens. So if you want the best chance at treating cancer, you having good dentition is actually a necessity. So next here. Okay, so I made this slide, and looking back, I think I should probably have changed the word common to potential, because, uh, you know, because there's so many different kinds of head and neck cancers, right? And depending on the location, the extent, uh, the treatment modality, there's a big variation in the prevalence of these side effects. Not everyone who gets cancer and gets cancer treatment is going to get all these um, side effects. So just please keep that in mind. So in this slide, the left column shows the tissues that can actually be affected. And there's the salivary gland, the teeth, the mucosa, uh, the muscles themselves, and the jawbone. And the right column shows what the effect is when the tissues in the left column are damaged. So, for example, salivary glands. If salivary gland is removed or damaged, that can result in decreased saliva production, and which will result in dry mouth, also called xerostomia. Teeth. Um, tooth structures could actually be affected. They can get weaker, and that makes them more susceptible to cavities. Mucosa, which are the soft tissues inside the mouth, um, that there's a direct, with the radiation, you could have what's called mucositis, which are basically kind of like sores. And indirectly, they can get opportunistic infections from radiation. The masticatory muscles that you use to chew, Um, and if that gets damaged, there's potential of getting trismus, which is a decrease in the mouth opening. And lastly, if the jawbone gets a high amount of radiation, uh, there is potential of what's called osteoradionecrosis. And that's when, after surgical procedures to the jawbone itself, the, uh, the jawbone may not be able to recover because of specific things that get done to the jawbone, which I'll get into in a minute. So let's see. So xerostomia, or dry mouth. I think the best way to understand why dry mouth has such a profoundly negative effect is that uh, there's a lot of benefits to saliva, right? Um, the saliva itself contains enzymes and proteins that are antibacterial, antifungal, and even antiviral. And it contains proteins that promote teeth mineralization. It helps to decrease microbial colonization of teeth. There's also a liquid component, and that helps to eliminate microorganisms, dietary sugars, and acids by dilution and swallowing. It helps to swallow. It also contains bicarbonate, which acts as a buffer to counteract acids from dietary sugars, from dietary intake and acids produced by bacterial fermentation of sugars. And that also helps to maintain a neutral pH. And that helps to decrease demineralization and promotes a balanced oral microbiota. So there's a lot of benefits to saliva. And so you can kind of tell, if you lose this, and sometimes you could lose it severely, you can have, profoundly negative side effects here. And so having dry mouth can cause the next side effect, which is cavities. So this is a pretty scary picture of someone with rampant decay. So the problem with kind of patients who get cavities with dry mouth and radiation is that these cavities are not very typical. Usually cavities are kind of in the chewing surfaces, in between teeth, but cavities in cases like this are usually along the gum line, and they may even encircle the tooth completely. So, and they also tend to progress very rapidly because there's less enamel along the gums. So what's really important, and we stress, is that patients get, very frequent recalls, very frequent cleanings and exams, just to make sure that things, get out of hand. We also recommend use of high fluoride products. That's essential. Next one. Okay, so trismus, and I'm sure there's others who are going to go into this as well, but it's a condition where patients lose the ability to open their mouth fully. And trismus can occur after head and neck cancer treatment in several ways. One way is that when surgery gets done in the head and neck region, especially around the jaw muscles, that can directly damage or disrupt the muscles, the tendons, and the ligaments, and nerves involved in jaw movement. And you could also have a scar tissue form at the surgical site, and that scar tissue can contract and harden, leading to fibrosis. And that also restricts the muscle's ability to stretch and the jaw's ability to open. Radiation treatment can also cause fibrosis and damage the muscles, contributing to the development of trismus. And finally, you could have indirect causes like inflammation and infection, which can also contribute to trismus. And then, so lastly, the side effect that we see sometimes is what's called osteoradionecrosis. So the definition of osteoradionecrosis is exposed, irradiated bone that fails to heal over a period of 3 months without any signs or evidence of actual cancer, persistent or recurrent tumor. So in the jawbone that received a large amount of radiation, the small blood vessels can be damaged in that area. And this can in turn damage the bone and lead to bone fractures and infections. And the damage to blood vessels can also prevent healing or delay healing after trauma or surgery to the jawbone. So by surgery, we mean dental extractions and dental implants. So in cases like this where the patient received a high dosage of radiation, 50 grays or more, we advise against any extractions or implants or other invasive dental alveolar surgeries. I mean, the key takeaway here is we want you to consult with your radiation oncologist or someone in my department before letting someone take any teeth out or letting anybody do dental surgery in your mouth. And then I just have some oral hygiene recommendations. So again, these are pretty common sense, but we always like to reiterate this. Brush your teeth at least twice a day. If you can brush after every meal, that's even better. Flossing is, yes, very important. We recommend you brush with a high fluoride toothpaste. It's a prescription strength that we prescribe, or use some sort of other high fluoride treatments, maybe like fluoride trays. Rinse 4 to 6 times a day with the mix of salt and baking soda. Half a teaspoon of salt, half teaspoon of baking soda in a cup of warm water. Avoid foods and liquids that have a high sugar content. We're not telling you not to, have any candy or, don't have ice cream, but, kind of in moderation because you don't want too much sugar and end up getting cavities, right? So, sip water often to hydrate, relieve your mouth dryness. Avoid products that with alcohol or phenol because those products tend to dry out your mouth. There are saliva substitutes. They kind of, your mileage may vary. There's a whole shelf probably at a drugstore, but some patients like one thing and not the other. So you kind of try different things and see what works for you. There are, I think, some medications that help salivary glands make more saliva. The effectiveness is, I think, again, not very good, but maybe it will change over time, and maybe maybe Dr. Ha may have other stuff that he may recommend. And the other very important thing is we want frequent dental cleanings and exams. Initially, we would recommend every 3 to 4 months. Again, just to make sure that things are going okay. And if we have to intervene, we can intervene early on and not after, you have a big cavity somewhere. And right. So, we work pretty intimately with the radiation oncology team, and they have a really good idea of how much radiation you received in certain areas. So they would tell us what the radiation level was. And so, almost tooth by tooth. So if you have a problem with a tooth in the bottom right, let's say, uh, we would they can send us the scans and we would be able to tell how much radiation you got here. So in that sense, we can kind of say, hey, you can get work done here. If you have to get it pulled out, you can. The risk is not high. Um, or, sometimes if the radiation is high, then we would say, we can't take this out. We have to keep it as long as we can. So that's kind of what we can provide um, before you actually go and do something without kind of knowing what the radiation level is. Yeah. Typically, inflammation in the gums is from plaque buildup. So, I don't know your specific history, of kind of your, recalls, frequencies and such, but right, usually it's from plaque buildup, unless there's some other insidious reason I mean, if you know, have great hygiene and you're seeing your dentist every 3 months and you got inflammation, then, hey, maybe there's something else going on. But typically, the first thing we would kind of, we would be able to see it visually, right? Whoever saw you, when they're doing the cleaning and they're kind of looking around, they can see the plaque buildup. Uh, if they don't see the plaque buildup and you have inflammation, maybe there's something else. But typically, it's kind of having the buildup there with the bacteria load. You mean the question is there a time after which any surgery is safe? Is that what you? Yeah. So um, there actually is no time. The radiation level, if whether it's 1 year, 5 year, 10 years, we still consider that area to have had high radiation. So uh, unfortunately, time is not a big factor. So if you had radiation that was very high in certain areas, then we would still recommend that you don't get any surgery done there, even after 10 or 15 years or whatever the time it is. Ideally, flossing would be best. I think, uh, and actually, if you really want to get into technical things about flossing, it's not the most exciting thing, but um, the best way to floss is actually to use a string, just a string, uh, because the best way to floss is to actually you go through the contact and you pull to one side and kind of go up and down that surface of the tooth, and you pull back and go back up and down the back surface. So that's kind of the best way to floss. Um, I mean, I have to admit, I don't do that myself all the time, but that's the ideal way to do it. um, there's like these floss picks with, there's like a toothpick on one end, and there's like uh, looks like a bow, kind of. A lot of patients use that, which is great, but that you can't create as much tension with that, or when you're, with the kind of your everyday string floss. Um, the water pick, it's you have to be able to reach everywhere, and it's I think every recommendation is still flossing is best. Whatever you do beyond that is great, but if you do just one thing, flossing would be it. It doesn't Water flossing doesn't replace regular flossing, actually. But if flossing is difficult, some of you have maybe dexterity issues, and so there is definitely a benefit to flossing. I mean, water flossing, but it should not replace regular flossing. You're talking about calculus buildup, right? Kind of the hard build, or also called tartar. So it's the hard buildup you're talking about, I think. And you're saying that uh, there's an increase because of. Okay. Yes. Right. So yeah, calculus, a lot of it has to do, yes, with kind of the anatomy of that area. Um, Patients who have crowded teeth, there's overlap. It it has to kind of do with like fluid dynamics, kind of your the chemistry of your saliva. Um, Wherever there's more pooling of saliva can cause more calculus buildup because like your hygienist was saying that there's more, it just sits there longer. And some patients have are prone to getting more buildup because of that in specific areas. So yes, I think that's true. Where if there's more, there's a change in your anatomy because of the work that was done, and or for whatever reason there's more pulling in a certain area, then uh, there can be more calculus buildup there. Unfortunately, no. I mean, calculus buildup is going to happen no matter what. A part of it, I think, actually, a lot of it is just kind of genetic. Whatever is in your saliva. Um, we have patients who brush and floss and they have no calculus, and we have patients who do the same thing and they got a ton. So unfortunately, you kind of need to know what works for you. If you get a cleaning every 6 months or maybe even once a year, and you get your cleaning and there's like a lot of buildup, then you should consider getting cleanings more often. Right. So you're doing the best you can. I mean, you're in the boat where I'm sure you leave the dental office and then you feel like you're walking right back in, right? Because it's so frequently, right? It's 3 months. Um, yeah, there's kind of these tartar control toothpaste, and I don't think they work that well. I mean, you're gonna get what are you gonna get with the buildup? Um, so unfortunately, there is no. Yeah, I think the buildup is gonna happen. You can, yeah. I mean, I kind of cheat because I have a tool at home and I stand in front of a mirror and I clean my own teeth, right? Every other week or something. So, but yeah, and there are cases where we think that there's less likelihood of getting ORN in the top jaw as opposed to the bottom. Um, so again, if something does come up and we get a call, we get a message, I would discuss it with, yeah, right, definitely, and also for sure if they want to do something in that area, right, yeah, you don't want to let them, cut that area open and do something or take something out. There's a big variation, I think. I think it's anywhere from 10 to 20, depending on uh, maybe the location. Uh, yeah, I think it's not 100%, thank God. But right. I mean, I think we're most concerned early on. You always bleed a lot during the cleaning. And then what was the other? Right. Or danger of doing deep cleanings. If it's done too aggressively, you probably want to avoid doing it too aggressively. Going down and just really damaging the gums. Um, I think as long as whoever does it is careful, I think it's fine. Um, Now, the bleeding, the deep cleaning would be recommended if your pockets are deep enough, right? Fours and fives, I mean, they're not that deep, right? Um, yeah, I mean, that's kind of, at a point of, do we, I think deep cleaning, if your gums are bleeding and your pockets are 4 or 5, you probably would benefit from doing a deep cleaning. Um, would you do it very frequently? I don't know about that. I don't know how much benefit you would get from doing it frequently. And if it is done, just to be careful that you don't, you know, go in and cut the gum a lot or just, do any real damage to the gums. Oh, hyperbaric. Okay, got it, got it. Okay. Um, I, from what I understand, there is no real proof or much conclusive evidence that it's useful or that how beneficial it is. Um, I think we discuss it because it's out there. It's not something we don't tell patients that, oh, if you get hyperbaric oxygen, it will really improve your chances of not getting osteoarterial necrosis. Um, but we just kind of put it out there because we want to let the patients know, um, and maybe it's something they can pursue just to have some peace of mind about it. But I don't think there's real, from what I understand, it's not a sure thing that's going to be really beneficial to you. An extraction, okay, yeah, I mean, we depends. Every tooth is different. Um, it depends on how it was pulled and what the condition of the tooth was when it was pulled, the location. So we can't really say just because you had a tooth pulled that it's whatever you're going to do next is going to be fine. Uh, it may very well be, but it's just hard to say. It depends on what the actual radiation plan was. Again, the radiation oncologist would be able to tell us how much radiation was given to where. Um, it could be that, depending on the size and the location, that maybe the actual radiation did not touch the tooth in the back, but maybe it did. So the best way to tell would be to actually get a map that tells us how much got where. Right. If the front of the mouth did not have this amount of radiation, then I'm sure it's fine. But that's something that we would have to look into. Uh, the short answer is yes. If the radiation in the fronts was not above 50 grays, which we can find out, then any dental work there is fine.